Okay, drugs for thromboembolic and peripheral vascular disorders. Second time. So obviously we're talking about clotting. So we're going to talk about anticoagulants. And for preview or for basic understanding, you might want to review hemostasis, or how does clotting occur, the clotting cascade, because that's how some of these drugs work. Aspirin has antiplatelet properties, so in a sense it can be used for anticoagulants. It prevents platelets from sticking together, and at a low dose. So typically when you see a patient that is being given aspirin at the 81 milligram a day dose, that is for its antiplatelet properties. At this low dose, it typically doesn't work for pain or inflammation or fever. Some patients will require a higher dose for antiplatelet, but typically they're just given for a low dose. You want to make sure to assess for use of other anticoagulants, including herbals, the 4 Gs, ginkgo, ginseng, ginger, and garlic. I remembered all 4. It's kind of like trying to remember the 7 dwarves. Usually you can remember 6, but not 7. Obviously, implications would be bleeding. Because aspirin is irritating to the stomach, it's usually given in enteric-coated tablet. If not, then the GI irritation is going to increase the risk of bleeding. Ticlopidine, not to be confused with a dipene. This is a pidine, or Ticlid, is another platelet aggregate inhibitor. It's used primarily for clients or patients who can't tolerate aspirin. Side effects include neutropenia, or low white cell count, TTP, thrombocytopenia purpura, and rash. Actually, I don't think that's what TTP stands for. I'll have to think about that one. Interactions include, obviously, other anticoagulants. Clopidogrel is Plavix. Clopidogrel is one of the prodrugs you might remember from Unit 1. It has to be converted in the liver to active metabolites, and it's the metabolites that do the work. Again, it's a platelet aggregate inhibitor. It can take 3 to 7 days to work, and it continues to work for 5 days after it is stopped. So, unlike aspirin, whose action pretty much stops once it's quit. Clopidogrel is primarily used for patients who have a history of clots. It does prevent clots, but we usually don't start it unless there's already been a problem. It can be taken with or without food. Nausea, vomiting, anorexia, diarrhea are common side effects that are usually self-limiting. Serious side effects again include TTP, blood dyscrasias, and obviously bleeding. Other anticoagulants would interact, and with all anticoagulants we want to consider, is the patient going into surgery, so that the drug can be stopped in the case of clopidogrel, a week in advance, or several days for other medications. Now, obviously, anticoagulants prevent the formation and enlargement of clots. Typically, when we think of anticoagulants, we automatically go to heparin or warfarin, because those are the two most common anti-clotting drugs. They each work in different areas of the clotting cascade to interfere with certain clotting factors. They're primarily used for thromboembolic diseases and prevent the formation of clots in veins. Heparin has a short half-life and is relatively immediate acting. It binds to antithrombin 2, so it inactivates some of the clotting factors and inhibits clotting. It must be given IV or sub-Q. It is not absorbed if given by mouth. The antidote to heparin is protamine sulfate. So if we see abnormal bleeding, we certainly are going to stop the heparin, or if that's not going to work fast enough, then we can give the protamine sulfate. It interacts again with other anticoagulants, NSAIDs, which have antiplatelet properties as well. Nicotine, digoxin, tetracycline, antihistamines, all inhibit the anticoagulation, enhance is what I want to say, enhance the anticoagulant effect. Warfarin works by inhibiting vitamin K. Now, vitamin K is needed in the liver to produce several clotting factors. Warfarin can take several days to reach its effect, in part due to the fact that it takes a while for the clotting factors that are already there to be cleared from the system. So it prevents these clotting factors from being made, but it doesn't destroy the ones that are already there. It also has a slow onset because it has a low bioavailability. Only 99%, or only 1% is used. 99% is bound to plasma proteins. So there's a high risk of drug-drug interactions with warfarin. And there's a lot of newer drugs being put out on the market. I know I've seen advertisements for at least 2 different medications that are being promoted to be used instead of warfarin. But your book doesn't talk about those yet, and so we're not going to go into them a lot. Side effects obviously are bleeding. The action of warfarin can take up to 10 days to quit because of the protein binding. The antidote would be to give vitamin K. It interacts with NSAIDs, diuretics, SSRIs, some antibiotics, steroids, the herbals, garlic, ginger, blah, blah, blah. All of these are going to increase the risk of bleeding. Now, sometimes a clot has already started, and we want to break up that clot. So we want to use something that ends with place, alteplase, retoplase, synactoplase. You already know that anything that ends in ACE means to break down. And so these drugs work by converting plasminogen to plasmin, which causes fibrin to degrade. And remember, fibrin are the little strings that keep the clot together. So if we break up those strings, then the clot will dissolve or break apart. Primarily, we're going to use these for things that cause a severe problem if there's a clot. The biggest problem, I guess, with using these thrombolytics is that they aren't clot specific. They're not going to target a specific clot. They're going to target whatever clot they come in contact with. And so we have to consider is there potential that we're going to break up a clot that we need? For example, in the case of an MI, is the tissue damage being covered by a clot, and would breaking up that clot cause that area to be so weakened that the heart muscle would break apart? So those are some things that we need to consider. We want to observe for abnormal bleeding anytime a patient is getting a thrombolytic. Patients that have active bleeding aren't going to be candidates for a thrombolytic. And if they've been involved in recent trauma, again, because of the risk of breaking up a clot that is preventing bleeding. Monitor the patient frequently during treatment, and obviously we want to ask about a history of anticoagulant use, including the herbals. Now, drugs for lipid disorders. These are your antilipidemics or anti-cholesterolemias. Patients can have high lipid levels for multiple reasons, usually related to diet, lifestyle, but it can also be genetic. Some people are lucky enough to have a gene that causes excess production of cholesterol, and so no matter what their diet and lifestyle, exercise habits, they're going to have high cholesterol. Keep in mind there's three types primarily of lipids. HDL is the good lipid, and LDL is the bad lipid. Bile acid sequestrants, we kind of mentioned this when we talked in Unit 1. Cholestyramine, cholecystipol, and cholecystipolin. Usually when we talk about grouping meds, we're talking about the ending. In this case, it would be the beginning. So typically when you see something that begins in chole, we're going to be talking about a bile acid sequestrant. So it binds cholesterol in the intestines, so it can't be reabsorbed. And this is dietary cholesterol, as well as cholesterol that the body has produced. The cholesterol then is eliminated in the feces, and primarily bile acid sequestrants lower LDL. They don't have a lot of effect on HDL, and it really shouldn't be used for patients with high triglycerides. Side effects typically are GI, simply because it's not absorbed. We're not going to see systemic side effects. Should be taken with food, should not be taken with other meds. Separate by 2 hours. Do not crush or chew. You're just going to get a mouthful of little beads. And keep in mind, it's going to absorb fats from foods, and so it's going to affect fat-soluble vitamins. So vitamins should be taken 2 hours on either side as well. Now, statins, or HMG-CoA reductase inhibitors, are probably the hallmark antilipidemics now. They typically end, or they do end, in statins. Otherwise, they wouldn't be called statins. But they can have a multitude of trade names. HMG-CoA reductase is a critical enzyme in cholesterol synthesis. So if we inhibit it or stop it, then cholesterol can't be produced. Now, keep in mind that cholesterol is produced in the liver, and that the highest production of cholesterol is at night. So statins usually work best when taken late in the evening, so that they're at their peak production when the liver is at peak production as well. So they work in the liver and metabolized by the liver. So we obviously need to be checking that liver function along with the lipid levels to see if we're doing any good. Typically, this is a lifetime drug unless diet and lifestyle changes improve the cholesterol. Liver dysfunction, myopathies, rhabdomyolysis, these are serious consequences of the statins. So we want to look for symptoms of liver dysfunction, right-sided abdominal pain, jaundice. Rhabdomyolysis symptoms are muscle aches, soreness, weakness. Hematuria might be noted because of the breakdown of the muscles. Grapefruit inhibits metabolism, which can increase toxicity, and when taken with warfarin can increase the prothrombin time. Nicotinic acid is also known as niacin, which is a water-soluble B vitamin. When taken in high doses, it can produce antilipidemic effects. It's primarily useful for patients with high, very low density lipoproteins. It also lowers LDL and triglycerides and has some benefit of increasing HDL, which is the good one. Side effects frequently limit the usefulness because people don't want to deal with the side effects. So the main side effect that people complain about is flushing and hot flashes, and that's because nicotinic acid has a strong vasodilating effect. But these hot flashes, if you've never had one, you can feel like you're being roasted alive. GI effects are also common: nausea, gas, diarrhea. It can cause gout, and of course, because of the vasodilating effects, we're going to see hypotension and dizziness. Again, it works in and on the liver, so hepatotoxicity and myopathies are a real possibility. Fibric acid agents are most effective in reducing very low density lipoproteins and triglycerides. They can increase HDL but have very little effect on LDL. We don't see them used much because they were replaced by the statins. Gemfibrozil can be taken with food. We want to monitor for GI effects, effects on muscles. The rhabdomyolysis or myopathy can cause gallstones and liver damage. Ezetimibe blocks the absorption of dietary cholesterol, similar to the bile acid sequestrants. It lowers LDL and triglycerides. Doesn't have very much effect on HDLs. Some GI discomfort, but seems to be well tolerated by patients. Should not be given with bile acid sequestrants. And omega-3 fatty acids. We hear a lot about omega-3s for heart health. Some research shows that they reduce the synthesis of triglycerides. Some research shows that there's absolutely no benefit to heart health. Regardless, they're not going to cause any harm, and they don't have any effect on the liver, so no myopathy, no rhabdomyolysis, and can be stopped if we don't see any improvement. And then sometimes the statins are taken with other medications, which may allow us to see better results, potentially fewer side effects depending on what it's paired with, and because we have fewer side effects, we may see better patient compliance. And that's the end of Unit 3.